Hi, this is Brian Kim. I'm going to share with you case number 203 in the best way to do cataract surgery series. This is an intumescent white cataract, and this is truly an intumescent white cataract. So you're going to see a 25 gauge needle puncture aspiration technique, and then double chop, cross chop. And you're going to see how efficiently double chop and cross chop really works in disassembling the lens, and it's actually safer to disassemble this lens in the context of an intumescent white cataract. So you can see this is the lens. You can see under the slit lamp that there's quite a bit of convexity to the anterior capsule. And you can see it has that milky, turbid appearance. I'm using the cotton tip to steady the eye. And this is a corneal marker which will help me to center and size the rhexis. Having the patient look up, which is to the left, and make my first paracentesis incision on the right side and then the left side, using the cotton tip to control the eye and immobilize the eye with each step. This is intracameral epinephrine, and then some intracameral air, and then some intracameral Trypan blue. Sometimes when the dye comes out, it comes out a little bit aggressively. The plunger gets stuck a little bit. You saw that there. But I always try to decompress and making sure that the dye comes out of the incision and so it doesn't go into the vitreous space. Filling the anterior chamber with dispersive viscoelastic, pushing the bubble and the dye out. And this is a triplanar corneal incision. I make a vertical groove. Place the blade into the deep part of the groove, tunnel, and then when I'm ready, I turn the eye towards me, and then I enter. This controls the length of the incision. And this is a 25 gauge needle puncture technique. You puncture the center, and then withdraw the plunger. And when you do that, you're going to see this milk start to come out. You see it right there. Yeah, there's quite a bit of that lens milk that's coming out. So I'm able to, there you go, yes, even more coming out. So I'm able to effectively decompress the bag. You saw as I pushed that fluid out, it was rather milky. And then I'm using the dispersive viscoelastic cannula to flatten the anterior capsule, but I'm also mechanically just trying to squeegee some of that milk out through the incision there that we made. Pushing some more viscoelastic through my para. And I'm going to do this as a two-handed technique. If I feel like there's some radialization forces, I can immediately push more viscoelastic in to stabilize the chamber. Go ahead and start the rhexis going around circumferentially, being mindful that there may be some radialization forces here. As long as you don't go too far peripheral, you won't get around that hump, which will tend to radialize the rhexis. And so you want to make sure that the rhexis is not too big in this context, because there's almost like a shelf out towards a peripheral capsule there. So I'm able to control the eye again with the cannula, and very controlled. Didn't feel like there was any risk of radialization here, so that was great. So that decompression technique worked quite well. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down. You can see the lens is already loose. It was probably loose before anyway. That's usually been my experience with these intumescent white lenses. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuchal material. But again, the lens is basically free moving. And so that's why double chop is so easy for these types of cases. You place the chopper around the rhexis edge contra-incisionally, point the phaco tip vertically sub-incisionally, and in a very controlled way, I'm able to split the lens very easily here. There it goes. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip and fracturing the lens in half. That is cross chop, doing the same thing around that first quadrant, and I'm able to fracture the lens in half again. This is a rather soft and chalky white intumescent lens. The thing that makes this risky is there's virtually no epinuclear material, there's virtually no cortical material. Therefore, you don't have any protection of the posterior capsule. And so this is almost like a Morgagnian cataract, where you have this white lens kind of flopping around in the bag. I think trying to sculpt this lens would be a little bit more difficult because it'll be flopping around in the bag. Not sure that's the best way to approach it. Using high vacuum near the posterior capsule is probably not a good idea either. And so you can see, using mechanical forces, turning the vacuum off, I'm able to disassemble this lens very easily and confidently, just using both instruments to fracture the lens in half, and smaller and smaller and smaller pieces. Very controlled, very easy to execute. You're not fumbling around trying to figure out where to grab with high vacuum, because anytime you go into the eye with high vacuum in this situation, you have to be very careful. And because you have to be very careful, that means one false step and you can buzz the posterior capsule or do something bad. But you don't have to worry about that at all when you're using mechanical forces. You're using the instruments to apply opposing forces, and then you just crush the lens into smaller pieces. There is no safer way to disassemble the lens in this context, in my opinion, because you're using your instruments to break the lens up. You don't have high vacuum. You don't have these high forces driven by the machine. You're using your two hands to break the pieces up. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Again, the bag is already very clean. Just removing some of those remnants and then switching to polish mode, polishing under the rexus edge, trying to peel out and remove any remaining cortical material that's stuck in the capsule fornix. Also polishing the posterior capsule as well. As I said, I don't really understand why you would approach a lens like this trying to sculpt it when it's already bobbling around inside the capsular bag. It's not really very supported. You don't have any epinucleus to protect you, so impaling it with high vacuum to hold the lens doesn't make any sense. Yeah, if you're experienced doing it that way, you're probably not going to run into trouble. But in my experience, if you play with fire too many times, you can get burned. And what I've learned with this technique is you're not playing with fire because you have such low risk, because you're using mechanical forces to crush the lens. You're not using high vacuum. So it's very, very safe, very, very easy. And since you're using your instruments, you have complete control over the situation. You're not going to accidentally buzz the posterior capsule with high vacuum. That's what happens sometimes in these cases. You're doing everything right and then something happens. So I'm pulsing BSS into the subincisional capsule fornix, and you can see there's quite a bit of lens material that was stuck there. Pushing cohesive viscoelastic to fill the bag, disengaging the infusion, and then coming out. And then I'm polishing with the sweeper, first on the left side and then the right side. So again, 25 gauge needle aspiration technique to decompress that intumescent lens. You saw that white milky material was coming out, and that worked really well. And then trying to squeegee the rest of that with the cannula, pushing viscoelastic through a paracentesis incision while you're doing the rexus, just to help maintain control of the rexus is also another nice tip. And the single piece acrylic lens is going in. Go in with irrigation off, activate irrigation, making sure the haptics are in the bag, tilting it and rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag, repositing the optic back down. Polishing under the rexus edge, then I'll remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, why would you go after the lens pieces and sculpt when the lens is bobbling around inside the bag? This is essentially almost like a Morgagnian, because there's a free-floating giant lens piece that's composed of epi and endonuclear material. There's hardly any cortical material. There's a lot of milk. And that's why there's that gap, because most of that peripheral lens material was that milk stuff. Well, you've removed all that. So now you have this lens material bobbling around within the capsular bag like a pinball. And so sculpting makes no sense. You can certainly lollipop the lens and hold it and then grab the lens. But if you're not careful with that technique, there's always risk that you might impale too deep and then puncture the posterior capsule. And so what other way can you do it? Well, you can do what I'm doing. You can do a mechanical fracturing technique, double chop to break the lens in half, cross chop to break the smaller pieces in half, and you can approach it from various different chopping angles. That's why cross chop is so versatile. Once you break those pieces into smaller and smaller pieces, you can emulsify those lens pieces because you're not using vacuum at all and you're not using ultrasonic energy at all with those maneuvers. It's very safe. All you're doing is keeping infusion on to keep that posterior capsule back, and you have complete control because you're using two instruments and you're crushing the lens with the instruments to make them smaller, and then using sparing amounts of ultrasonic energy and vacuum to remove the lens pieces. Of course, when you're removing the lens pieces, I'm keeping the chopper back, protecting the posterior capsule. And this is why my rate of posterior capsule rupture has gone down. Again, the rate was very low before, but this has now essentially reduced my posterior capsule rupture rate to 0 during the lens disassembly steps. And again, this is why I feel like this is the best way to do cataract surgery, especially in the case of an intumescent white cataract. So I hope this was helpful to you, and I thank you for your attention.